Welcome to the OMM Medicine's module on clinical shoulder anatomy in under 10 minutes. Here's a picture of the humerus with many of its anatomical landmarks listed, and this picture is from our gross anatomy of the shoulder video, where we go into more detail about each of these anatomical structures as well as the neurovasculature that runs near the humerus. So we can have three major types of fractures to the humerus, and those are going to be proximal, distal, and then mid-shaft. And we're going to use the surgical neck as that landmark to make the distinction between proximal fractures, which will obviously occur proximal to the surgical neck, and then the mid-shaft and distal fractures will both occur distal to the surgical neck. So it's important to know that we are going to use the surgical neck as the landmark to depict whether it is a proximal or a distal fracture. So let's start by talking about the rotator cuff muscles, because they are obviously very important muscles that stabilize and perform actions on the shoulder, and it is comprised of four major muscles. These are going to be the supraspinatus, infraspinatus, teres minor, and subscapularis. Now we go into much more detail about the rotator cuff muscles and any pathologies involving them, as well as the tests used to assess their integrity, such as the full can and empty can tests, on our website in the upper extremity section. So be sure to check that out if you're looking for more information about the rotator cuff muscles. However, we did want to include some of the key points that you should be familiar with about each rotator cuff muscle, specifically their innervation and then the role that they perform on the shoulder, because these are very commonly tested subjects on both the USMLE and the COMLEX exam. So let's go through some of these points briefly here. And the supraspinatus and infraspinatus are both going to be innervated by the same nerve, which is the suprascapular nerve. Teres minor will be innervated by the axillary nerve, and then subscapularis is easy to remember because it is innervated by the subscapular nerve. The role of each muscle is also very important to be familiar with, especially the supraspinatus, because this is going to be the only muscle responsible for abduction of the arm for the first 15 degrees of motion. So if a patient is having trouble abducting their arm or initiating abduction, but if the physician moves their arm into, let's say, 100 degrees of abduction and they can hold their arm in that position, then it is likely an issue with the supraspinatus muscle, because this is the only muscle that's going to be responsible for initiating abduction for that first 15 degrees of motion. The infraspinatus is going to be responsible for external rotation of the arm, as well as teres minor, and you can remember that because there is an ER in teres minor, which stands for external rotation. Teres minor can also perform adduction of the arm the same way that subscapularis can, although it's also important to remember that subscapularis is going to be responsible for internal rotation of the arm as well. Now let's talk about shoulder dislocations, and there are two major types: the anterior and the posterior dislocations, and the anterior dislocations are much more common. Almost 90% of all shoulder dislocations will be anterior dislocations, with the posterior shoulder dislocations being much more rare. And the reason that we see a much higher prevalence in anterior shoulder dislocations rather than the posterior dislocations is because the anterior aspect of the humerus and the shoulder is not well protected, whereas the posterior aspect of the humerus and the shoulder has a lot of other structures like muscles and ligaments and tendons that prevent the shoulder and the head of the humerus from moving posteriorly. And the most common cause of anterior dislocations are falls or trauma to the shoulder. So if you have an elderly patient, it would likely be a fall. And if you have a younger patient, maybe they're playing sports or football and they get hit, then we would suspect that trauma was the major cause of the shoulder dislocation. And posterior dislocations are more common in patients who have spastic movement of their shoulders, so people who may have seizures or epilepsy, or those who were electrocuted. Shoulder dislocations are more common in males, especially those between ages 15 and 30, and this should make sense to you because the most common cause of an anterior shoulder dislocation is trauma, and this group of individuals tends to be a little bit more rowdy, and therefore you would expect a higher incidence of trauma to the shoulders in young men. Now, one of the major complications we look for in a patient who has a shoulder dislocation is axillary nerve damage. Remember that the axillary nerve is going to come off the brachial plexus and then run around the head of the humerus. So when we have a shoulder dislocation, it's very easy for the axillary nerve to become damaged. And remember that the axillary nerve is going to innervate the deltoid muscle. So if a patient does have a shoulder dislocation and they develop shoulder numbness or shoulder tingling, for example, we would suspect that the axillary nerve may be damaged. And one other key finding that you should be familiar with, especially for test questions, is how the patient's arm presents in the clinic, as this will help you differentiate between anterior and posterior dislocations. So for an anterior dislocation, we are going to expect the arm to be abducted and externally rotated, and for posterior shoulder dislocations, we would expect the arm to be adducted and internally rotated. So two very important things to know when approaching a question about a patient who may have a shoulder dislocation is how the patient's presenting in the question, meaning is the arm abducted, externally rotated, internally rotated, and so on, and how this shoulder pain started. Are they a football player that got tackled, or maybe they're an elderly person who fell? Maybe they have a history of seizures. Maybe they are an electrician who got shocked and then was found. And so these two things together will help you differentiate whether it is an anterior or posterior dislocation, or maybe it's not even a shoulder dislocation at all. And the diagnosis and treatment of a patient with a shoulder dislocation is fairly straightforward. You'll use the history and presentation along with a shoulder x-ray to diagnose it, and then you will reduce the shoulder in order to treat it. Now let's talk about proximal humeral fractures, meaning damage to the humeral head or the humeral neck. And remember that the word proximal in this sense means that it is going to occur proximal to the surgical neck of the humerus. And the most common cause of proximal humeral fractures is going to be trauma, most commonly due to a fall. And these patients are going to come in, they're going to have pain with motion of their arm, obviously, and then they'll also commonly have the arm adducted against their body because it's painful to move, so they try and keep it as close to their body so that it moves as least as possible. Now, a very common complication of humeral fractures is going to be avascular necrosis of the humeral head. And the reason for that is because any damage to the humeral head or the humeral neck will also likely damage the anterior and posterior circumflex arteries, which supply blood to the humeral head. And so when you disrupt the blood supply to this area, you'll get avascular necrosis of the humeral head. So it's very important that you remember the names of the two arteries we just mentioned, the anterior and posterior humeral circumflex arteries. And it's also important that you remember that avascular necrosis is a common complication of a proximal humeral fracture. And one other complication that may arise, but it's less common than avascular necrosis, is damage to either the axillary or subscapular nerves. And when you have a proximal humeral fracture, it's also very important from a clinical standpoint that you assess the distal pulses of the arm. So you would test the ulnar and the radial pulses, for example, in a patient who has a proximal humeral fracture. And the reason you do this is to make sure that there are no neurovascular structures distal to the site of the fracture that have also been damaged. The diagnosis and treatment of proximal humeral fractures is pretty straightforward. The diagnosis will be made based on clinical suspicion, and then an x-ray should also be obtained, and then the treatment will consist of any combination of casting, surgery, or an orthopedic surgery referral if the fracture is severe enough. And the last humeral and shoulder dysfunction we'll talk about are humeral shaft fractures. These are largely caused by trauma, such as car accidents or a direct blow to the arm. And humeral shaft fractures have one very high yield complication that you should be aware of, which is damage to the radial nerve. And this should make sense to you because remember that the radial nerve runs in the posterior aspect of the humerus through the radial groove. So patients who have radial nerve damage secondary to a humeral shaft fracture will present with loss of function of all of the roles that the radial nerve supplies, such as loss of extension of the wrist, fingers, and elbow, and then loss of sensation on the back or the dorsum of the hand. Now, some other complications that may be seen in a humeral shaft fracture, but that are much less common than radial nerve damage, are damage to the brachial or axillary arteries and damage to the pec major or deltoid, as remember that both of these muscles are going to insert on the humeral shaft. And diagnosis and treatment is going to be the exact same as we saw with proximal humeral fractures, and that is going to be diagnosis via clinical history and x-ray, and then treatment with any combination of casting, surgery, or orthopedic surgery referral. And I wanted to mention on this last slide that some of the other dysfunctions of the shoulder, such as adhesive capsulitis, rotator cuff tears, and biceps tendinitis, as well as all of these special tests used to diagnose these conditions, are all covered in another module in the upper extremity course on our website. So be sure to check that out if you need to review these topics. And that brings us to the end of this module on clinical shoulder anatomy.